All right, welcome everyone to our On the Pulse series. I am Chris Fortman. I am the CEO of the Minneapolis Heart Institute Foundation, and I want to thank everyone for making time to join us today. We are grateful to be together. So before I introduce our keynote today, I would like to tell you just a little bit about the Minneapolis Heart Institute Foundation. We have been doing cardiovascular research and education for 38 years. We are an independent nonprofit organization who partners closely with the Minneapolis Heart Institute that is at the Abbott Northwestern Hospital within the Allina Health System. We could not do this important work without those partners. Our mission is to improve cardiovascular health through innovative research and education. And if you look at our circles, you'll see research and education up top happening to improve clinical care. That is at the core of everything we do. This picture shows research happening and education happening. You can tell by the look on people's faces that we love research and we love education. We have over 200 active studies happening that touch over 2,000 patient lives. We are just thrilled about those numbers. Half of that research falls into the category of physician-initiated research. So our own physicians come up with key questions that they want to answer because of what they're seeing day in and day out in their clinical practice. The other half of our research is industry-sponsored clinical research that is bringing the latest therapies to our patients. All of those young faces in the white coats show our interns. We have a wonderful summer internship program because we're dedicated to educating the next generation of healthcare professionals. In addition to the next generation of healthcare professionals, we offer continuing medical education through grand rounds, and we're always so proud of what our physicians do with their research, and that is publish it. Our dissemination is about 200 plus manuscripts annually in peer-reviewed manuscripts. It speaks very loudly to the caliber of the physician researchers that we work with. Here are just some more pictures to demonstrate the great work happening through our physician researchers. You'll see first in the world, first in human achievements here. You'll see the happy faces of our patients that have benefited from our care. And you'll see community efforts here to educate those around us in what is the latest news in taking care of your heart. And we're dedicated to improving care not only here in Minnesota, but across the nation and across the world through our research and protocols. None of this would be possible without the generous donations of our friends of the foundation. All of this research is supported through philanthropic support. So just a big shout out to what you all make possible day in and day out here at the foundation. We are in the news currently. A lot is happening on looking at your cardiovascular health with COVID-19. Dr. Retu Saxena, who I will be introducing shortly, will speak more to that. We are also taking part in some emergency clinical trials right now, so things have not come to a stop during this time. And if you're interested in learning more on our physicians' perspective on what the current status is in healthcare, please do visit our website to learn more about what is happening around your heart and COVID-19. With that said, let me tell you a little bit about our speaker today, Dr. Retu Saxena. She grew up in Brookings, South Dakota. She did her undergraduate degree in sociology at the University of Minnesota, as well as graduated from medical school from the University of Minnesota. After medical school, she did her internship and residency in internal medicine at OHSU in Portland, Oregon. She stayed in Portland and completed a critical care fellowship as well. Her cardiology fellowship was completed at the University of New Mexico, where she stayed on as faculty. During her time at the University of New Mexico, she was actively involved with managing and practicing at the UNM Women's Heart Clinic. She then moved to Minnesota. Woo! We're lucky for that, to work with the region's largest women's heart clinic at the time. She eventually directed the echocardiography laboratory at her prior organization. She now is a cardiologist with the Minnesota Heart Institute. Her interests are women and heart disease, prevention and non-invasive imaging, as well as cardiac critical care. I love this part. She is also the mother of 2 active girls, an avid reader, and a passionate gardener. Retu is playing a very important role in our Penny Anderson Women's Cardiovascular Science Center. Through her leadership, we are looking at many important questions that are specific to women's heart health. Retu is also listed as a top doc year after year in the Minneapolis St. Paul magazine. We are so proud to have her leadership here, her passion here, and for her to speak to all of you today. Retu?
Thank you, Chris. Thank you, Chris. It's a pleasure to be here this afternoon. Let's see if I can do this. So I'm going to talk to you today, this afternoon, about hypertension, cardiovascular risk factors in the time of COVID. So for those of you who've probably seen me speak before or you haven't, my usual passion is talking about women and heart disease. And I talk about cardiovascular risk factors as it pertains to women and heart disease, primarily. That's my interest. That's my area of research through the Penny Anderson Cardiovascular Center as well. So usually I talk about how women's heart disease epidemiology is different than men's. So in this vein, I thought I would talk a little bit about SARS-CoV-2. By no means is this a COVID-19 talk. It's a talk about risk factors in the setting of COVID-19. And if you have more questions about the virus itself, I would have you tune in, go online, look up the Minneapolis Heart Institute Foundation's On the Pulse talk by Steve Bradley that was given April 27th. I watched it, it was phenomenal. I stole some of his data, so you might see some duplicative data from there. But this is the pictorial demonstration of the SARS-CoV-2 virus. It's a single-stranded RNA virus that actually attacks something called the ACE2 receptor on cells. It's amazing to me how quickly we've moved in the last 5 months. The first reported case was December 8th, 2019 in the Hubei province of China. And since then, it's only been 2 months since the World Health Organization designated the COVID-19 a pandemic, only 2 months. And the epicenter in the last 5 months from February and March of 2020 shifted from China to Europe, primarily in Italy. And then in about March and April, it shifted to New York, the United States, as the epicenter of this pandemic, and it's kind of stayed in the United States as the epicenter. I think these numbers are staggering. As of May 4th, which is the last set of statistics I had when I made these slides, about 3.6 million people tested positive for coronavirus or COVID-19, and we've had about 252,000 deaths worldwide. Forward. This is the Johns Hopkins dashboard. If you want to watch this day in and day out, you can. It targets every country. It targets the world numbers. But as of May 4th, 2020, the United States had 1.18 million cases of coronavirus and about 69,000 deaths. So to go back to my timeline, to put it in perspective, in the last 2 months, March 5th, we had 227 confirmed cases. April 5th, we had 337 confirmed cases in the United States. As of yesterday, we had 1.2 million confirmed cases in the United States. The death rates, March 5th, 12 people had died in the United States from coronavirus. April 5th, 9,643 people had died from coronavirus. And as of yesterday, 71,000 people in the United States died from coronavirus. The majority of those, again, have been in New York and New Jersey. Again, I'm not going to belabor the infection from coronavirus. Happy to answer questions the best that I can. We know that about 80% of people who are infected by COVID-19 have a mild to moderate disease type, and that includes things like fever, dry cough, fatigue, but you can get a runny nose, you can get a sore throat, you can get rhinorrhea, which is really just a runny nose, and you can get aches and pains. We know that from the time you get infected to that first 14-day mark, you're actually shedding the virus, whether you're sick or not, you're actually able to expose other people to the virus. The PCR test that everybody's talking about, that's the nasal swab test or a sputum test, turns positive in the first 14 days. And then as you are infected and you start developing antibodies, in that first 3 to 5 days, you get what's called an IgM antibody titer. And then over the course of 14 days, you get actual antibodies to it. But 16 to 20% of people who get infected end up with a severe disease form or rapidly deteriorate and end up being either hospitalized, in the ICU, or dying. And that severe disease form is slightly different in that you see really excessive shortness of breath. You get shortness of breath with it walking, just even walking the length of a normal hallway. You feel incredibly short-winded. We find that you get hypoxic, which means your oxygen level goes low, and your respiratory rate can go up. What's actually happening is you're developing a coronavirus or a COVID-19 pneumonia. Your lungs are changing, and we can see that on radiologic testing, such as with CT scan, where you actually see a change in the way the lungs can look. Of that, a subset of patients will go on to then develop ARDS, which is acute respiratory distress syndrome, septic shock, where your body's not getting blood flow the way it should, so your tissues aren't getting perfused, or an acid disturbance. What we're learning the more and more that research comes out is that these individuals also develop a clotting disorder where they tend to make more blood clots. We're seeing more strokes in people that we wouldn't have ever expected to see strokes in. And then you can see myocardial injury and myocarditis. When you look at this data that's being published, I mean, the amount of data that's been published on this virus in the last 5 months is mind-boggling. It would fill this room and then some. But the mortality rates are everywhere, depending on who you read and what nation you're looking at. But on average, it's about 2 to 5%. We know that the rates vary by death. The rates of death will vary by age and sex, but we know across the board, whether it be China, Spain, Italy, the United States, that we know that as you age, your risk of developing the severe disease and rapid deterioration is more apt to happen. And then the other thing is it has a male predominance for worse outcome. Not sure about that. We can venture some hypotheses as to why. Usually when I talk about cardiovascular risk factors, I talk about how those risk factors then down here translate to the various array of diseases that I normally see. We take care of people with coronary heart disease, which is that plaque formation in the heart arteries, but we also take care of aortic diseases, which are related to our risk factors. We take care of heart failure and weak heart muscle, otherwise known as cardiomyopathy, which is related to those risk factors, arrhythmias, and then vascular disease in either our legs or our brain, which again are related to these risk factors. I thought when I showed my array of diseases, I'd also put up the array of diseases that are caused by the COVID-19 as it pertains to the cardiovascular system. It turns out that this virus has an overwhelming immune response, and that immune response, as well as the virus itself, may affect the blood vessels themselves. So our blood vessels are lined by these cells called the endothelium, and that endothelium can be attacked by the virus itself, leading to issues with coronary artery disease, plaque disruption, and actually leading to heart attacks. It can cause an acute injury to the heart muscle, leading to myocardial damage. The inflammation can cause an acute injury to the heart muscle, leading to myocardial damage, which then leads to heart failure, arrhythmia. I thought how telling is it that these risk factors that we're going to talk about, which lead to coronary heart disease, acute coronary syndrome over here, heart failure or cardiomyopathy, again, heart failure over here, and arrhythmias, the overlay between the coronavirus and the cardiovascular disease array that I normally see is very, very strong. And so again, one would think given the fact that these disease processes are very strong, that I went too far. It finally did advance. Given the fact that the risk factors overlay, I was impressed that the disease processes themselves have such a strong association. These are the traditional risk factors for heart disease. We learn about this all the time. This is the Know Your Numbers campaign, the Simple 7 campaign from the American Heart Association. These are our traditional risk factors. Believe it or not, I spend most of my time talking about emerging risk factors for women and heart disease. And so it was good for me to go back and talk about our traditional risk factors. We know that men over the age of 50, women over the age of 60 are at increased risk for developing cardiovascular disease. Cholesterol issues and family histories play a huge role in our development of heart disease later in life. Diabetes, smoking, and hypertension is what I'm going to belabor to you today, because that's where the overlap with coronavirus exists. And then for the point of this talk, peripheral artery disease and cerebrovascular disease count as pre-existing conditions for coronavirus. But what you should know for heart health is that peripheral artery disease and cerebrovascular disease, such as stroke, actually impacts your risk for developing heart attacks later in life. So again, as I spend most of my time giving talks about women and heart disease through our Penny Anderson Cardiovascular Center, I spend most of my time talking about the left side of the slide. My area of interest is primarily women and pregnancy, gestational risk factors that then impact us later in life. So today, I'm going to focus on this side of the slide, for which I haven't done in a while, but we will get there. Hypertension, diabetes, smoking, and obesity is really what I'm going to focus on, because that's where the overlap between COVID and cardiovascular risk factors exist. So again, 4 months, 5 months of this pandemic, in that time period, the amount of studies that have been published are staggering. When I say it could fill this room, I'm not, it's not a joke. It's not meant to be over counting. They are so much data out there. A lot of times they hit the lay press before they have the opportunity to actually even get published in a journal. And they're not all peer reviewed. I tried very hard to mark which hadn't hit journals that were peer reviewed through my slides. When we divide up the coronavirus infection, there's the mild to moderate disease, which I'm not really going to talk about, but then there's the hospital admissions, the ICU admissions, and then the death, which is thought of as the severe form or the critical illness part of this disease. When you look at studies, what we have found is that across the board, those individuals who end up having the more severe form of coronavirus tend to be older. They tend to be male. We're going to talk about obesity and hypertension and diabetes at length, but they tend to have other concomitant chronic heart problems, such as heart disease, such as stents or bypass, heart failure, chronic kidney disease, and strokes. And so this is already old. This was published at the beginning of April of 2020 from the CDC, looking at pre-existing conditions and whether or not you ended up having the critical illness part of corona. And what we found is those people who smoked, were former smokers, more apt to be in the ICU. Individuals with chronic kidney disease, more apt to be in the ICU. Individuals with cardiovascular disease, including heart failure, more apt to be in the ICU, and those people with diabetes and chronic lung disease. Just like with heart disease, if you have one risk factor, your risk increases. But if you have 2 risk factors, your risk multiplies. If you have 3 risk factors, your risk multiplies. The same is true of coronavirus. The more pre-existing conditions you have, the higher risk you have. Again, the risk factors exerting a multiplier effect. So let's talk about some of these risk factors. Hypertension. The first question that I'll always get asked is, what is hypertension? So I'll start even more simply. What is blood pressure? Blood pressure is the force exerted against the arterial wall as the heart pumps blood. So that top number is as the heart squeezes, the bottom number is as the heart relaxes. What is high blood pressure? High blood pressure stretches those vessels, those arteries, beyond a healthy limit. So I like to think about blood vessels. The blood vessels in our body, the red ones are called the arteries. They take blood to tissues, our toes, our fingers, everything that makes us us. And the blue ones are veins, which returns blood to the heart to get oxygenated. Arteries are lined by these cells called endotheliums that allows the muscular arteries to relax or constrict based on many, many different factors. And over time, that chronic overstretching from high blood pressure leads to changes in the inside lining of those blood vessels, leading to scarring and tearing. It can lead to weak points, which can then dilate and rupture, which are aneurysms. It can lead to clotting in the wall itself or plaque formation. And then that increased work as those blood vessels get stiffer and tighter, they don't relax as well as they used to from chronic hypertension, leads to an increased workload on the heart and eventually heart failure. So again, hypertension poses a definite risk to our hearts. What's normal? As of 2017, the new normal is less than 120 over 80 millimeters of mercury. When you look at the United States, about 1 in 2 adults lives with hypertension in the United States. That's a lot of people. If you happen to be over the age of 65, about 75% of those individuals over the age of 65 have hypertension. And it's overwhelmingly has a propensity to individuals of color. We know that individuals who are African American tend to have more hypertension than those individuals who are Caucasian, Asian, or Hispanic. Why does hypertension matter to a cardiologist? Well, it's a huge part of what I do day in and day out in clinic and on the hospital service. Hypertension increases your risk of having a stroke. First-time stroke sufferers, 8 out of 10 of them will have hypertension. First-time heart attack victims, 7 out of 10 of them will have hypertension. And if you present with heart failure, more than likely 7 out of 10 of those individuals will have had some form of chronic hypertension. Again, it's really important to know what your numbers are. That's number one. And when you know those numbers, what's normal? Less than 120/80. Well, what do we do as it starts to creep up? Believe it or not, if you're below 130/80, we actually start recommending lifestyle modification. You should be working on your diet, eating more vegetables and fruits, exercising, trying to avoid those things that raise blood pressure, such as over-the-counter pain medicines and alcohol. If your blood pressure is over 130, but not quite over 140 yet, you may end up on therapy depending on what other multiplier risk factors you're on. And if you're over 140/90, you absolutely should be treated. And in this country, in order to treat blood pressure to goal, you're usually on 2 or 3 different classes of blood pressure medicines. Again, women and heart disease, that's my passion. So I am going to tell you, over 65, women are more likely to be hypertensive than men. And again, in this country, although about 47% of people are treated well for blood pressure who have hypertension, only about 29% of women get adequate blood pressure control. Why treat blood pressure? Well, it turns out that just dropping our blood pressure by 12 to 13 millimeters of mercury, so 12 to 13 points on that blood pressure cuff, you decrease your risk of having a stroke by about 37% of the 37%. You decrease your risk of having coronary heart disease or blockages by 21%. You decrease your risk of dying from cardiovascular disease by about 25%. And you decrease your risk of all-cause death by 13%. So pretty good reasons to drop your blood pressure, I would say. So what about hypertension in the time of COVID? Well, I think this is really interesting when you look at how we got to talking about hypertension in the time of COVID. So when these studies first started to come out, this is late February, early March, there was an overwhelming number of Chinese studies that got published. They were case series. That would be like me telling you about the 12 patients I saw on Friday and just describing each of them to you and trying to make some associations based on those 12 individuals that I saw. There were lots of case series. Not all of them were peer reviewed and not all of them were controlled for other risk factors. And so those studies demonstrated an increased rate of hypertension in those individuals that ended up in the ICU or ended up dying, but they didn't do a great job of controlling for age. And as we know, with better controlled studies, age is definitely a risk factor for doing worse with COVID-19. The other thing you should know is that hypertension is not as well controlled in China as it is in the other parts of the world, even though we're not doing great, but 50% of us are meeting our blood pressure goals in the United States. Hypertension in China is about 30 to 40% well controlled. And then again, there's always causal and temporal when we think about the reason things happen. Hypertension keeps company with heart failure, coronary artery disease, chronic kidney disease, strokes. And we know that those conditions lead to an impact at increasing your risk of doing worse with coronavirus. So when we think about hypertension and COVID, I wouldn't necessarily think that hypertension itself is as much responsible for the worst outcomes as it is the fact that hypertension is more prevalent in people as we age, as well as the comorbidities that it takes. The other thing that happened when this all came out in the news is, for those of you who read the newspapers, the Chinese studies also demonstrated a worsening of the coronavirus in types of hypertensive control agents. So there are these blood pressure medicines that a lot of people are on, and somehow they got this bad rap at the beginning of all this, give or take March or April, that you do worse if you take these blood pressure medicines. And those blood pressure medicines in particularly are ACE inhibitors, angiotensin converting enzyme inhibitors, such as lisinopril, or angiotensin receptor blockers, ARBs we call them, such as losartan. Well, again, these drugs are used in heart disease, heart failure, They're really good blood pressure control agents. They're also really, really good medicines and keep people with heart failure alive longer. And so about the time that these studies were hitting the press, the American Heart Association, the European Society of Cardiology, the American College of Cardiology said, whoa, wait a minute, we don't actually have data to say stop these medicines, and we recommend not stopping these medicines. So just within the last week, okay, this is how fast this happens. Just within the last week, 3 articles got published in the New York Journal of Medicine. These are peer-reviewed articles, peer-reviewed journal, that looked at exactly this question. Does the type of blood pressure medicine that you are on impact how you do with coronavirus? This top right graph right up here is from Tim Henry's group of researchers. And I point out Tim Henry because he is a prolific researcher for the Minneapolis Heart Institute Foundation. But what this shows us, if you look down here, there's these 3 lines right here: receiving ACE inhibitors, receiving angiotensin receptor blockers, and receiving statin. If you are on this side, you're good. If you cross the midline, you don't meet statistical significance. What this shows us is that it did not matter if you took an ACE inhibitor, an angiotensin receptor blocker, or a statin. It did not increase your odds of dying from COVID-19. What did increase your odds of dying in this study? Being older, above the age of 65. This is being female, which is on this side of the line. On the left side of the line is protective. So being a man increases your risk of having a worse outcome with coronavirus. Coronary artery disease, congestive heart failure, having a rhythm abnormality, being a current smoker, and then having COPD. But what blood pressure medicine that you were taking at the time that you looked at these individuals did not impact your risk of doing poorly with coronavirus. And what's more, another study that came out actually looked at ACE inhibitors, angiotensin receptor blockers, and compared them to the other types of blood pressure medicines that we have, and that's what's displayed down here. There was no difference across the board, regardless of what blood pressure medicine you were on. So what should we do? Well, we should make sure our blood pressure is controlled. If you happen to be on an ACE inhibitor and an angiotensin receptor blocker, please do not stop them, especially if those drugs are being used to treat your coronary artery disease or your heart failure. In my line of work, I call them life-preserving drugs, and so it's really important to continue those medicines. So what about diabetes? Normally, I would tell you 88 million people in the United States live with diabetes. Diabetes is a huge risk factor for heart disease. It actually increases your risk about 2 to 3-fold for heart disease. About 280,000 heart attacks annually are attributable to heart diabetes. And if you have diabetes, your chance of dying from your heart is about 60%. Again, from the Chinese mortality data that came out, it turns out that diabetes impacted mortality in coronavirus about 7.3% compared to other things like high blood pressure or cancer. So from the American Diabetic Association, they make a really strong point about making sure your blood sugar is controlled if you have diabetes. Believe it or not, blood sugar control may actually decrease your risk of getting the infection, as having a high blood sugar is a chronic inflammatory state and can lead to a decrease in or a waning of your immune system. But it may also decrease the risk of severity from the illness. So control your blood sugars if you have diabetes. It's really important to manage coronary artery disease and chronic kidney disease should you have it concomitantly with your diabetes. Exercise, I'm going to get back to, but exercise has a huge role in improving immunity as well as controlling blood sugar. We know that. And then this I thought was really fascinating. This came from the American Diabetic Association. If you have diabetes and you haven't updated your seasonal flu vaccine or your pneumovax, it's really important to do that, as you can end up getting a sequential infection or an overlapping infection to the coronavirus and then having a poor outcome. So obesity. Prior to our current pandemic, I would have said we were in the epidemic that is obesity in this country. It turns out that over the age of 20, about 40% of Americans are obese. I'll define obesity in a second. What's really sad is about 20% of 2 to 19-year-olds have a diagnosis of obesity. So what's obesity? How do we define it in the medical world? Obesity is having a body mass index greater than 30. What's a body mass index? It's a way of calculating your weight to your height. And really all you have to do is Google, or you could probably Apple phone it, you could Safari it, you could Bing it, and just type in BMI calculator, and you'll get a BMI calculator. You put in your height, you put in your weight, and then you get really sad when you see the results. But really, ideally, you want your body mass index to be less than 25. Why does it matter? Well, as our body mass index starts to go up, whether we're men or women, we actually start to lose life. If your body mass index is greater than 40, regardless of whether you have diabetes, high blood pressure, arrhythmias, heart failure, all of which obesity can cause, regardless of whether you're just obese or have any of these other things, you start lessening your life expectancy. In fact, a BMI greater than 40 reduces your life expectancy by 10 years. So it's really important to control your weight. This is brand new. This really is like hot off the presses. Some of it is not peer reviewed. It came out within the last 2 weeks. So this is the United States data. And interestingly, we don't have a ton of data from China about obesity. Where obesity started first rearing its head when it came to coronavirus was actually Italy. And they started noticing that those individuals who got admitted to the hospital or the ICU or had poorer outcomes were obese. But really, the United States kind of made it absolute by these studies that have been published. So the New York City data up here, really quickly, what they did was they looked at obesity by age and BMI. And it turns out that if you're over 65, yes, I've belabored this point, you tend to do poorer already. But if you happen to be under the age of 60 and had a BMI of greater than 35, you were more apt to be admitted. If you happen to have a BMI of greater than 40, you had a 3.6 increased risk to be admitted to the ICU and do poorer. Not published, but data that should be coming out from Orchner Health in Louisiana, which is this large multi-center health system, showed that there was a 71% increased risk of ending up in the ICU, anywhere from 46 to 261, depending on which group they looked at, if you're obese. That was a greater risk than if you had heart disease, diabetes, or chronic lung disease. And then finally, this is the New York University Langone data. So it's a big hospital that kind of was in the middle of the coronavirus epicenter in New York City. They had 4,103 patients with coronavirus. Of that, 1,999 were admitted. When they looked at those patients, the things that led to hospitalizations the most was, of course, being older. The older you are, the higher the odds ratio of you getting admitted. 75 versus 65 to 74, both carried a high odds ratio. But look at this, if your body mass index was greater than 40, your odds ratio for having a critical version of this illness was 6.2. Compare that with heart failure. Again, I talked about how having bad heart problems to begin with puts you at risk, but heart failure only had an odds ratio of 4.3. So being obese was more predictive of having a critical version of this illness. Nicotine, tobacco, I usually don't talk about this because, again, most people don't smoke anymore, but people still smoke, which always stymies me and surprises me. Normally, 480,000 deaths in the United States are attributable to nicotine or tobacco abuse. I usually talk about vaping because I talk about women and heart disease and pregnancy, so I'm usually talking to a little bit of a younger individual. And people think vaping is the safe alternative to smoking. It's not. It in and of itself can increase your risk of having a stroke or a heart attack or heart disease. But when I looked up tobacco and COVID, it was just amazing. Of course, if you smoke, you're more apt to end up in the ICU or on a ventilator. There's some really interesting data that thought that maybe the reason that there's this difference between how men and women do from coronavirus may be due to smoking. The Italians looked at this. They actually have the same rate of smoking in men and women as opposed to most other countries where more men smoke than women do. And they didn't find that that was the reason why men did worse than women. To me, I just think about the fact that every time you smoke or you vape, you're taking something from the counter and you're touching your mouth with it. In fact, the World Health Organization just published a bulletin last week about how you shouldn't be sharing your water pipes, your hookahs, whatever other pipes you might be smoking through, because again, it's a fomite, it's a way of getting that bug in you. So really, I should just have a giant slide that says, don't smoke. Quit smoking if you do. Stop. Get help if you need it. Really quickly. Okay, so I was going to talk about obesity, hypertension, diabetes, and tobacco because those were the big four overlap. I have a hard time talking about heart disease without talking about mental health. I know this is a strong area of interest of some of my colleagues here at the Minneapolis Heart Institute Foundation. And for me, when I talk about women and heart disease, we know that women who have heart disease are more apt to be depressed. But if you happen to be depressed and happen to be a young woman, you're actually more apt to do worse with heart disease. There's absolutely an overwhelming association between anxiety, stress, depression, and poor outcome when it comes to heart disease long term. We know that you make poor choices when these things are acting up. We haven't started studying mental health in the coronavirus population yet. And I do wonder what's going to happen given the fact that our patients are more isolated now than they've ever been before. You spend 28 days in the ICU and yet your family can't come and visit you except on the Zoom or on the webinar or on the FaceTime. And then we really haven't started to look at, but this is hitting the press, on how the COVID-19 pandemic is affecting the stress of my colleagues, of physicians, frontline workers, our grocery store clerks, the individuals who deliver our food and our groceries, with all the stress that they're into right now, the stress of the overwhelming numbers and the frustration of the lack of PPE, and just watching people die at rates that they had never seen in their careers. I wonder how the mental health is going to impact everything it is that I do later in life. As we know, stress worsens the big four: hypertension, diabetes, smoking, obesity, and cholesterol. So more to come. I assume somebody is going to start thinking about it. Usually when I give talks about risk factors, I then proceed to talk about how to prevent them. A year ago, which now seems like a lifetime ago in literature, right? A lifetime ago, the American College of Cardiology came out with this beautiful ABCDE of primary prevention for coronary artery disease and heart disease. I'm not going to belabor, that's aspirin. I'm happy to answer questions if you have aspirin. But it really was focus on fixing your blood pressure, focusing on dropping your cholesterol, not smoking, diet and getting that weight down, making sure your blood sugar is well controlled, and then exercise. Exercise is that magic bullet, the panacea of all that makes us well. It turns out that exercise keeps us alive longer. It decreases our rates of stroke. It decreases our rates of onset of diabetes if you're at risk for diabetes. And what's more, and what most people don't know, exercise boosts immunity. It improves our mental health. So again, if you can, get outside, walk in the sunshine, dance in your living room for about 20 to 30 minutes. Definitely don't go to the gym. All those machines are infected. But get out and move. It helps with the social isolation. What about COVID-19? Again, avoid close contact with people who are sick. Avoid touching your face. I wear glasses, so it's really hard for me because I want to push them up all the time. If you are sick, and you're well sick is the way I'd word it, you just have a fever, some runny nose, you have a cough or a sore throat, stay home, stay away from other people. I'm going to come back to that in 1 second. If you sneeze or cough, use a tissue, throw the tissue away, wash your hands for 20 seconds. You can all Google best songs to wash your hands to. They are out there. Clean and disinfect objects that you're going to touch. I'd like to leave you with this before I answer questions. If you're so short of breath you can't walk across the hall, go in, be seen. We are here from you. I am awaiting you. If you're having chest pain, whether you're male or female, go in. Don't stay at home. Don't be afraid of coming to the hospital and have your heart attack at home. Just because we want you to stay at home when you have a fever, runny nose, or a sore throat, doesn't mean that if you can't walk from here to those slides that I'm sitting right next to, and you're so short-winded that you can't move, doesn't mean you shouldn't come in. I'd rather you be safe in the hospital, getting checked out for your heart attack, than unwell at home. And with that, there's this Zoom Q&A walkthrough. That's not my slide. So I'm gonna turn it over to our moderator here. Thank you so much.
Yeah, thank you very much, Dr. Saxena. That was an excellent, very thorough presentation. We really appreciate you sharing your time and expertise. For those of you that can't see me, my name is John Rickards, and I am the Education and Communication Specialist here at the Minneapolis Heart Institute Foundation. So the way that we're going to do Q&A today is to please use the Q&A pod located at the bottom of your screen. And to access that, all you have to do is drag your cursor to the bottom of the screen. A control bar will pop up, and please click on the Q&A pod and enter your question. And with that, it looks like we have a few questions already. So this individual has coronary artery disease, They have 2 stents that were placed in 2016. They also have type 2 diabetes. This person is 64 years old and an avid cyclist. his question is he at risk for COVID-19? Is he in the vulnerable group?
So there's two questions there. One, is he at risk for COVID-19? Just because you have high blood pressure, diabetes, happen to be over the age of 65, happen to be a gentleman, doesn't put you at any more risk of having or getting the bug than, say, me, not over the age of 65, not a gentleman, or Chris. Our risk of getting COVID-19, unless we happen to be immunosuppressed or pregnant, or on some form of having other issues with our immune system, is not any greater than anybody else in the population. So just having the cardiovascular risk factors, having heart disease, doesn't change our risk of getting COVID-19. We're at the same risk of getting it as everybody else in the population, unless you happen to work in a hospital, and he didn't mention that. You might be at slightly higher risk if you happen to be in healthcare. The other risk factors, yes, if you do get COVID-19, it's really important to control those risk factors, which it sounds like he's doing, because the more out of control they are, the more at risk he is for having the severe form of the illness. So again, chances of him getting it, just as the chances of all of us getting it are pretty good. The question is, does that necessarily mean he gets the severe form? Not necessarily.
Great, thank you for that. So this individual is talking about the risk factors, and they ask, do the same concerns apply to former smokers or people with controlled high blood pressure?
So it turns out the better controlled your blood pressure is, you do better. We don't necessarily have that as data, but we definitely do recommend controlling your blood pressure. And then last, the one slide I did show from the CDC, former smokers, and usually we think that's within the first 5 to 10 years of quitting, does put you at increased risk for having the critical illness form.
Thank you very much. This individual asked, how do you calculate your BMI?
Oh, so I usually use my calculator on my phone, which is over there, but it's really your weight to squared height. And honestly, I'm terrible at doing math in my head, so I just have a calculator on my phone. But what I would urge you to do is, if you have access to the computer, and since you're watching me on a webinar, I assume you do, just type into Google BMI space calculator, put in your height and your weight, make sure it's inches and pounds, or centimeters and kilograms if you happen to be imperial or metric. Make sure that you're in the right units, and it should spit out a number and probably some recommendations.
Thank you very much for that. So can you recommend, or is there a way to measure your blood pressure at home?
So there are ways to measure your blood pressure at home. So when my patients ask, I usually recommend, and again, I have no financial interest in this, but my nurses really like the Omron arm cuffs, and they are electronic blood pressure. If you happen to live with a nurse or a doctor, get a manual cuff. They're a little bit cheaper. Recently, my patients just told me this, and I found that they're actually quite useful. I assume you guys can see my Apple Watch. They now have watches that not only track things like the Apple Watch does, which is your heart rate, your heart rhythm, but they actually have a watch-based blood pressure cuff. And so far for my patients, as I've been doing a lot more telemedicine, I've actually found it to be useful. So think about that. I think Omron makes one too. Again, I have no vested interest in the company that is Omron, but they do make a good product. So we like the electric automated arm ones better than the wrist ones, though. They tend to correlate better.
Thank you very much. So how can we stay up to date on what our blood pressure is during the virus, or if it's changing, without being able to visit our physicians? I know you pretty much just
buy a blood pressure cuff.
Yeah. Excellent.
See if your insurance will cover it.
Thank you for that. So do you think MHIF will get involved with long-term research of COVID and these risk factors?
We are. We're doing. We're looking at the play between heart disease and COVID-19. Just recently, my good friend and colleague, Santiago Garcia, looked at STEMI data, heart attacks that we rush right to the cath lab. We call them ST elevation myocardial infarctions, and why there had been a downturn nationally for STEMI March 2020 versus March 2019. He is also looking at how to manage heart attacks in the time of COVID, those that are both persons undergoing investigation, we call them PUIs, those that are COVID positive, as well as other individuals who are presenting with heart attacks. So absolutely, we are running a lot of ongoing trials and looking and sharing our data across the board. I would urge you to check out Steve Bradley's on the Pulse talk from April 27th, because he is carrying on a lot of research when it comes to COVID and cardiovascular disease.
Thank you very much. Could you speak on the reported increase in strokes since the COVID-19 outbreak?
Yeah, so I actually had to look all this up. There's been an increased risk of hypercoagulable states. So what does that mean? That means there's an increased risk of clotting with coronavirus, more so than we see with, say, and again, I wanted to stay away from this comparison, but I'll just say it, the seasonal flu. And we're seeing this clotting disorder leading to large blood vessel clotting, not just small blood vessel clotting, and it showing up as strokes, especially in people that we wouldn't have expected, younger women and younger men. And so again, thus far, there's all these reports out there. I haven't yet seen the why, what factor puts those individuals at risk. If you happen to be hospitalized with coronavirus, it's really, really important to be on blood thinners. But right now, there is no recommendation for those of us that are walking around normally and active to be on prophylactic blood thinners. But definitely, if you're hospitalized with coronavirus, you should absolutely be on blood thinners.
Thank you very much.
Prophylactic doses, sorry.
Not a problem. This individual writes, has there been enough testing to reliably determine mortality rates in the greater U.S. population? If not, when does that point arrive?
I like that question. I am wondering when that point arrives myself. So I have nothing to do with the control of testing in the United States or the state of Minnesota, but I would agree that's a really good question. I ask it every day. I don't think we have tested enough people to actually understand. I should use case fatality, which is probably the better statistical term than mortality. But again, the publications are mortality. We don't. We have cases. We know how many cases we've tested. We're just in Minnesota as of this week ramping up our testing, and we're doing about 500 a day. That's not enough. That's not enough. But again, I don't know when. I wish I did, but I don't.
Thank you very much. I think you may have touched on this briefly, but how much exercise specifically should a person get weekly to avoid hypertension?
To avoid hypertension, so the recommended daily exercise is 30 minutes a day, 150 minutes a week. To avoid hypertension, again, that's tough. I didn't go into exact details of hypertension. Hypertension is a very, very complicated disease process. I tried to simplify it. For whatever reason, we walk around thinking hypertension's the heart's fault. It's not. Your genetics plays a role. How your kidneys work play a role. How your renin-angiotensin-aldosterone system works plays a role. How your brain and your nervous system works plays a role in hypertension. And so again, best data, we do know that things like aerobic exercise will reduce the amount your blood pressure goes up. Absolutely. It actually improves the way the blood vessels relax. So all good things. Things like Tai Chi, yoga, and meditation have been studied. Yoga primarily in women. It turns out that women who do yoga 3 times a week actually can drop their blood pressure by about 10 points. So all good things. Again, that's probably not impacting the heart so much as it is impacting the stress hormones that our brain tends to release and raise our blood pressure. Like the mental stress of giving a talk.
Absolutely. So this individual writes that they have hypertension that's controlled by medication. They have a pacemaker and AFib and also have a paralyzed diaphragm. They jokingly ask, should I hide in a cave? But I think what they're asking is, how long should they isolate for? Or are they at a greater risk?
So I would say the pacemaker and the AFib doesn't increase your risk of getting the disease process any more than any other risk factor that we talked about today. The paralyzed diaphragm actually gives him or her a diagnosis of lung issues. And yeah, anybody who has chronic lung issues, be it a paralyzed diaphragm, COPD, asthma, they are higher risk should they get the virus. And so no, don't go hide in a cave. Definitely wash your hands, 20 seconds. Find a song you like, play it over and over again. Make sure you clean your fingers really well. Sneeze into a tissue, drop the tissue in the trash can, wash your hands, and wear a mask. Try to stay away from people that are not your family members.
Thank you very much for that. It looks like we have a couple of questions about cardio pregnancy. And basically the questions are, what is the recommendation for pregnant women in regards to protection from COVID-19? And if you had a cardio pregnancy experience in the past, are you at more risk than an average person?
So the regards to pregnant women and avoiding coronavirus, again, it's the same as the general population. Wash your hands, stay away from sick individuals, cover your face, drop the tissue, wash your hands. Don't touch your face as much as possible. If you start feeling ill, I would call your provider, your OB, if you're actually pregnant sooner than later, especially if you're spiking a fever. In terms of if you had a gestational risk factor later in life, again, the risk of you getting coronavirus is the same as the general population. But if you have developed hypertension, which we know gestational disorders can lead to increased rates of hypertension 1, 5, 10 years out from your pregnancy, or if you've developed diabetes, or if you've developed heart disease or heart failure from your gestational risk factors, then again, should you get coronavirus, you're more at risk for developing the critical illness form.
Thank you very much. What sort of daily aspirin regimen would you recommend to help with stroke possibilities?
So again, right now, there is no coronavirus stroke prevention aspirin recommendation. So I'm just going to stop right there. If you're asking about aspirin for primary prevention of heart disease and vascular disease, each individual needs to be calculated separately. That's why I didn't belabor the point of aspirin on the ABCDE of the primary prevention. What I recommend is talk to your doctor, make sure that they feel that your prevention risk is lessened more than your bleeding risk is increased by taking a daily aspirin regimen. It's what I do for my patients. It's what your doctor should do for you.
Thank you very much. Looks like we just have a few more questions. And this individual writes that they're a young male with a history of heart failure with no other morbidities. This person has had LVAD for a few years, and he is also an avid cyclist. And they're wondering if there's any studies coming out regarding LVADs and the response/outcome to COVID-19.
Not that I know of. I mean, that's very, very, very specific of an individual, and I'm not sure if, I'll finish and then maybe Chris can help answer, but I'm not sure that they've looked at that population per se in the literature I reviewed from New York, Italy, and China, because it's a very, very specific individual. Chris, what were you going to add?
We were just going to tell the individual that tomorrow Dr. Peter Ekman is speaking, and he may be able to answer that.
So if you didn't hear Chris, because she's not on the microphone, Chris Fortman reminded me that tomorrow my good friend and just phenomenal doctor, Peter Ekman, who I've known for a really long time, and I can't say enough good things about, we'll be talking about heart failure, updates in heart failure, and he may actually have more information, particularly about LVADs and coronavirus.
Thank you very much. It looks like we just have time for one more question here. And that question is a fairly general question, but what is a reasonable time expectation for the development of an effective vaccine for COVID-19?
Wow. Again, things I do not do. I am not working on any vaccine trials that I know of. If you think about how vaccines come out, vaccines take years to develop. You have to make sure they're safe in human testing. I think even with this idea that we're going to produce them at a rapid pace, the best scientists, and I do have friends that sit on the IDSA board, the Infectious Disease Society of America board, 18 to 24 months I mean, there are human trials going on. Again, I would urge you to look up Steve Bradley's On the Pulse from April 27th, because he talks about some of those vaccine trials that are going on. But there are vaccine trials that have just started in Europe and man. Those are phase 1 trials. They have to get through 3 phases of trials and then ask for FDA or the equivalent in Europe's approval. And again, it's the whole, how do we have rigorous testing and peer review of all of this data? This takes time. Those studies that I showed you about ACE inhibitors and angiotensin receptor blockers, 5 months. And again, so much has come out, but it just got published last week. So it took that long to get that data rigorously looked at to then publish, to understand that information. So I would say my best guess, and it truly is a guess, I think we're 18 to 24 months out from a vaccine that actually hits the public. And then the question is how protective is it? Things we do not know, a lot of we do not know. So with that, I'll say thank you and turn back to Chris.
Thank you very much.
Thank you, Dr. Saxena. So I just want to thank everyone for making time to join us today, and just wanted to point out on the slide different ways you can stay connected with us on Facebook, Twitter, LinkedIn, Instagram. Please do visit our website. There's a lot of great information, more about the Penny Anderson Women's Center and updates on cardiovascular health and COVID. So great resource there for you. If you need anything, please email us or call. Because of your support, we're able to do this great work, and we appreciate it. I know in many ways we're looking at different things to entertain us, so I just have to say a couple things about May. May's been very exciting so far. On May 4th, we had the Star Wars, May the 4th be with you. Yesterday, May 5th, was Cinco de Mayo, and today we kick off National Nurses Week. So thank those nurses in your life. And just recently here to celebrate the frontline providers, we had a fabulous flyover by the National Guard of all the hospitals in the Twin Cities area. And I'm just looking at my friend Retu if there's something else.
International Hypertension Day, May 13th.
Okay, May 13th, National Hypertension Day. So we can start practicing the exercise and other good habits that Retu recommended to us. So if you're looking for some more exciting information and knowledge, please join us tomorrow where we'll have Dr. Peter Ekman share more about heart failure research with us. So thanks again, everyone.